on PCSK9, and then we'll venture in as he prefers into some of the other lipids.
Yeah, for
That's perfect.
so if I get paged, it's not that I want to run away, but I'm attending. So that's the whole issue. This afternoon, I would like to discuss with you first a kind of a warm-up to the PCSK9 inhibitors. I do not know if people have already prescribed PCSK9 inhibitors or seen patients with it. I will tell you how it was discovered, how it was developed, and to prepare you, I think once you want to prescribe or use, it will be a battle with the healthcare assurance, and I will go in detail about it because now about 5% of the patients who may be treated with PCSK9 inhibitors are only paid for. So the others are completely denied. Then I tell you what you need to do. And you see here the whole history. Before the PCSK9, I would like to give a brief introduction regarding the Ezetimibe, and you would think that is a déjà vu. Everybody knows Zadia, but perhaps you do not remember that just before New Year's Eve, and it's very rare, that the FDA called the voting committee back, and then they requested a new vote, and so 5 people regarding the approval of the Ezetimibe turned it down. I do not know, are you aware that the FDA is now very hesitating regarding the whole Zadia? I will show you some inside details which have not been published, and you will be a little bit amazed that so many people, and I'm the first to raise my hand, so many people prescribed Zadia, and you will be surprised if you look the whole Improve It study under a microscope. Before that, we will discuss a little bit, very briefly, the guidelines, what you will implement when you go to the board exams, and then how it will change, not only based on the PCSK9, because there is no outcome. Then secondly, regarding where are we going, because AHA, ACC have their own guidelines. I will show you the pitfalls, because if you look to the guidelines, it's like if you're 40 years and younger, you seem to be immortal. Because the guidelines say you only start the statin, and most of the people, if they are older than 40 years, and the people in the cath lab have seen that a lot of people, and Dr. Ganesh Ravindran will confirm, that there are a lot of people with coronary artery disease before the age of 40, and perhaps if they would have treated earlier, he would perhaps less complicated cases when they were 50 or 60 years old. The National Lipid Association have the guidelines. I will not discuss with you because the nephrologists and the endocrinologists have decided to have their own guidelines, because you know the frustration in hemodialysis or end-stage renal disease, statins do not protect anymore. And let's start with the beginning. Do we go? And the reason why I bring that up is, do you believe that LDL cholesterol is a risk factor or a risk contributor? If you tell that in a room, you will see that about 50 or 60% will be very upset. The others will smile, because if you consider the LDL cholesterol as a risk contributor, that means that the cholesterol in each person will not be linked with severity of atherosclerotic disease as everybody thinks. And I think people who have been in the lipid clinic, and recently Jeremy and Beltran last year have seen people with nearly no elevated lipids, have huge coronary artery disease, and the others where the vessels have been soaked in fat have nearly minimal lesions or what the interventionalist would call non-significant, despite it can cause a lot of problems on long term. But you see immediately the whole debate, because who has seen the editorial from CVS Pharma in the JAMA, the medical officer, that she, because within about 6 or 8 weeks I have to chair at the National Lipid Association a whole session regarding PCSK9, and the first speaker that is put is the medical officer, because CVS Pharma made the statement, if you want to use PCSK9 inhibitors, you have to be sure that the price can save you $50,000 in quality of life. So that means the conclusion was that CVS Pharma does not want to deal at this moment with PCSK9 inhibitors. That's already kind of a problem. You will see then a little bit in Euro, and Jeremy Markovic is not here. He is just back of Italy. And today the exchange euro-dollar has gone up. It was yesterday 1.09. Today it's 1.14. So he has not to sell it. The euro will go up again. So you see here the whole number, and that's a kind of the whole industry behind the lipid lowering business. Does everybody need to be treated equal, or should we be much more selective, tear down the wall of the 45 years, what to do? And you will see it when we talk about the familial hypercholesterolemia, because now the JAK ACC wants to give new guidelines against the AHA-ACC and the other one. So it's very sad, it's so confusing, and on top of that, I think it's very bad for the medical world here in the United States and the scientific organizations. In contrast, the Europeans have one guideline. Now we will be at the 5th recommendation and guideline in about 2-3 years. So nobody will believe it anymore. The first question is, what do you obtain regarding risk reduction? If you lower the LDL cholesterol, and we can open the discussion later on, because you would say, Duprez, you will not tell anything regarding HDL. At the end, I will say a little bit, because you saw the funeral service of the third TTP inhibitor. I think Merck is in the process, I think, to prepare the 4th funeral service, and that there is still one left. So one of the most important meta-analysis, I think, is the cholesterol treatment trial collaboration, published about 5 years ago in the Lancet, where you see that in the US we are accustomed to use milligram per deciliter. In most of the world, they will use lipids in millimole, but I have converted it for you. It's about 1 to 40, and then per 40, or a little bit less, milligram per deciliter cholesterol reduction, you will see that the risk reduction is minus 20%, coronary heart disease that minus 90%, any major, it's about 23%, CABG, PCI, unspecified, the revascularization. So I would say, if you lower the LDL cholesterol with about 40 milligrams per deciliter, in most of the cases, you will reduce the risk and the events with about 25-20%. So that means we can do better, but the question is, what do you use to do better? You could say niacin has been used and abused for so long time. If you remember the TRIVE, the TRIVE trial, where they compared niacin plus laprubibant, which suppresses the flushing, versus placebo on top of a statin in 90,000 people, there was no benefit at all of the niacin. That's the reason why most of the healthcare insurance will not reimburse anymore the niacin and so on. You see a lot of people running to Walmart, still flush-free niacin, Costco still promoting it, but the niacin which is sold there is pure little bit of vitamin B. If the people want to take it, do not start to argue. Just check your cholesterol, their cholesterol with about 3 months, and you will see the natural variation about 5%, so it doesn't do anything OTC. The whole debate came regarding the Sparkle trial. Everybody remembers the Sparkle trial. That post-stroke, it's atorvastatin 80 milligrams versus placebo, reducing a second stroke. And the answer was yes. But the very interesting finding in the reduction of atherothrombotic strokes was again about, it's always between 20 to 25%. But you see immediately that the whole issue is hemorrhagic stroke. In fact, if they would have not seen hemorrhagic stroke in the Sparkle trial, the benefits would have been even more. So that, and that was not a new finding. If you look to all these epidemiological studies from the 70s, the 80s, and then you have the paper in circulation 1991. First author David Jacobs from epidemiology, Jim Newton was on board. Stamler, who is still around from Chicago, well, yeah, he was very critical. Nobody could believe it. But if your LDL cholesterol on genetic basis is going below the 25, independently what you do, you are at risk for more spontaneous brain bleeding. So you see, I take you now already for the PCSK9 because there are people running around at these levels. What will happen? Will they see, at this moment, they have not seen more brain bleedings, but everybody is concerned. Neurocognitive function. So the FDA requires with the PCSK9 that now each PCSK9 has to be evaluated on neurocognitive function. And then I do not know if people read the whole, just before the holidays, started Cafe Pharma, and they still have not identified the group because there is, like Ralph Nader started that movement against the statins. There is a kind of on internet Cafe Pharma which started to spread the message that PCSK9 would increase the brain infection. So that was the reason that Sanofi and Amgen brought all their scientific personnel before Christmas to their headquarters, and they had to work till after New Year to sort out to go back with a reply to the FDA, but the FDA is very silent about it because at this moment they have not identified who is behind. So if you would see it, there is no evidence because otherwise they would have come out with more restriction, more search for that. Yeah?
You know, Dr. Scott Wright from the clinic gave a lecture as well about lipid, and he mentioned that there's a lot of people that are running lipid LDL level 25 in Africa. They're all fine. I mean, do you think that the rate reduction in the LDL is affecting the blood-brain barrier, or is the absolute value?
I think it's mainly could be the blood barrier. Or we have you need some cholesterol for the membrane. That's the whole issue that nobody knows what the cause. At this moment, 25 is not an alarming phase. It's mainly that you see in the epidemiological studies, and of course, the only thing in the Sparkle, and that's the reason that I brought that slide in, that the hemorrhagic stroke cannot be ignored because if you think hemorrhagic stroke, it's more African American. The Caucasians is also thrombotic, embolic. African Americans have more hemorrhagic stroke. But then, if you go mainly from we have such a melting pot, like people from the Caribbean, from all these islands, that they come here and they have cholesterol because you will hear, and I very much believe for the dosing regarding it, it's function of ethnicity, like Asians, you never give kind of maximum statin. They could be even at much more higher risk because what you would say is blood pressure. But what if there is an underlying mechanism? They still have not figured out since 1991 why, if you have a very low cholesterol, you start to bleed more, and you bleed in the brain. You do not bleed somewhere else, and that's a kind of a mystery because your cerebral perfusion is one. The cerebral circulation has an autoregulation, so you have a huge window with pressure change. Could be due to membranes, but I think you will see the next years and months there will be more research, and then I will give you a little hint in which the PCSK9 will go after the whole outcome trials are published. They will go also for diabetes, because the whole issue is if you are too low, could it be that you would see also more bleeding in diabetics with retinal vasculopathy, because your retina is a part of your brain. So that's a little bit concerned too. And then I do not know in which camp you are. You have seen it over and over again. Are you a believer that lipid-lowering therapy is only to do with the level, or do you think it's more anti-inflammatory? I would like to have a vote to see who believes it's pure cholesterol. Who says it's more anti-inflammatory? Yeah, the statin, I think at this moment we will talk only about statin because the rest is not protected too much in atherosclerotic reduction. I think niacin is nearly out. We have all the orbital trials. I think now the trial. I think the fibrate accepted and Civil fibrate has not. If we have time this afternoon, otherwise in March, regarding triglycerides, there are a lot of medications on the development to lower the triglycerides, because that's the factor cardiovascular risk factors. I think all of that, with cholesterol and so on, is not protected. Can you go to a comment? Yeah, I think from that diagram, is it a dose response? Yeah, but that's the reason that I bring it up is because that's the secret weapon of all the people who believe that it's pure LDL cholesterol, and now I'm very malignant. This will be the secret weapon of the company that developed the PCSK9, because they have to convince first the payer, the physician, and then the patient that the low the cholesterol, the better. And perhaps it came a little bit later, I thought to say, is cholesterol a risk contributor or a risk factor? That's the whole around, because you see the people, some people are running around with cholesterol, they never have a serious heart disease, and the other was 110, 130, they are catastrophic 38 or 50 or 60. You see from if you do this plot, you think everything is LDL mediated, but of course, if you go to Paul Ridker, and I can now tell you there's another guy, the editor of clinical chemistry. It's not a journal that we read every week, every month. He is so skewed regarding the sensitive CRP, that if you cannot tell an article of the sensitive CRP in Cardiovascular journal, the impact factor of clinical chemistry is 7. Also bad, it's higher than APDB. He will take it. But we have the study, the Iceland Danet, the retrospective was favorable in outcome. The prospective study of CRP was not predicted from the Iceland Reykjavik study, and it's the answer of the whole cytokine cascade. And if you cannot sleep during the night or you're on call, and if you want to read very nice editorial review from 2 British authors who didn't believe CRP, Katie and Tybo, with a lot of European friends in the 90s, they couldn't publish anywhere, and they chose that title to CRP or not to CRP. For the people who know Shakespeare, it's to be or not to be, the B to the CRP, where they go through the whole literature where the CRP was not predictive. And the reason is CRP is not predictive if you start to adjust, for instance, by interleukin 6 or the dimer and so much. So we will come back, and the reason why I bring that in, because you will see that I cannot give you an answer today regarding the PCSK9 inhibitors. Suppose that the PCSK9 inhibitors do not affect the inflammatory parameters, then it could be that they are all behave like other lipid lowering medication, that they are not so good than everybody think. And I am not pessimistic, but I found it strange in the whole marketing race, because you have now the 3 QMAPs, 2 QMAPs, the Repatha and the Praluent on the market. You have the third, the humanized, not the real antibody from Pfizer, and there is still one going on. There is nearly no company which has done any paper about any anti-inflammatory parameter, and they all say we are so busy, we cannot do it. This was not the case with the statin, so I'm very curious to see that. Now let's, yeah?
Because the statin, they have altered some of the, they have to know that PCSK9 don't have a CRP relationship. Probably put it in the paper, right?
Well, of course, it's a very costly, it's the first time in cardiology, especially for atherosclerotic disease, that they start to have antibodies. So it's a whole different price range, a whole different thing, and I think their budget is tight because all these companies have seen that, for instance, Pfizer lost $1 billion with torcetrapib. Roche lost about 600 million. Merck is a catastrophe because they lost the fight, the niacin and the laptopibam, and now I think they are shaking for anacetrapib because Johnson & Johnson lost, they laid off a few weeks after they announced that the result was fertility. There was less difference than 5%. So they are very concerned about that. So let's go now a little bit regarding the guidelines, because you will see once you will utilize, or we will enter the phase in your practice regarding the PCSK9 inhibitors, they will say you have to have proven atherosclerotic cardiovascular disease, and you see here the guidelines, and I put in italic but you all know these findings. The whole controversy, if somebody is in heart failure, that the statin do not work anymore, but that does not mean if you start to treat somebody with coronary artery disease and he or she develops an ischemic cardiomyopathy, that you now say, okay, it's too early for euthanasia or palliative care, I will start to stop your statin. That will help a little bit. So I think there needs to be much more studies to sort out, because the whole question is ischemic versus non-ischemic cardiomyopathy in case inflammation. And I do not know if you are aware, the NIH has put just the light on green to fund a new statin trial exclusively in HIV patients. Greenspoon from Harvard is the PI, but the statin will be pitavastatin. So the Japanese 10 milligram very weak, and I think they will try to recycle that statin exclusively for the HIV population, where they will look 6,500, 50% placebo, 50% active, and then they will look also for the morphology of the plaque, because HIV patients calcify much less than the regular atherosclerotic disease. Second, what the healthcare assurance want is the LDL of 190 milligram per deciliter, and I think that magic number comes mainly because historically the 4S, the simvastatin Scandinavian survival study, the inclusion was 190. And then I think my two critiques are the 40 to the 75 years with diabetes, and you see the LDL without clinical atherosclerotic disease, and then the 40 to 75 regarding the risk 7.5. And this is very sad, because you have, especially for the youngsters who will need more therapy, that it could be that in the future they fall all through the crack, because that the healthcare assurance say, okay, these are people younger than 40, we will not pay for it. And that's what we see now recently. Regarding the dosage, the critique, I think you all know it, but I think for the board exams you need to do what they recommend, because all the questions are written. 75 years older and less. If I will show you a little bit regarding the approved trial, you will perhaps start to change your mind, but you will see why. Because do we need to change the dose around 75, or can we still go with a high dose? Personally, I would say it's much better if you start with a lower dose, you go slow and in a safe mode, than with a high dose, because otherwise they come back, and nobody ever wants to start a statin. We see it over and over again. Regarding the LDL, it's the same thing. The diabetes, 7.5 risk. You have seen all these articles that people were criticizing it, and then the Framingham risk score. And I think in that whole risk score, what is so sad is that they have put the Hispanic population with the Caucasian population. I think Hispanic population are on a fast trajectory for atherosclerotic disease, but it's much more based on insulin resistance than on LDL. These people face HDL, triglycerides problem, insulin resistance, and perhaps in March, when I come back, we can debate that now the new treatment of diabetes or a lot. Perhaps most of you are familiar with the Emperec trial in diabetes. Yeah, but this is out of the scope. That some new anti-diabetic medication were leading to risk reduction of about more than 40% in heart failures. Is it due to blood pressure control or to better control of diabetes? So I will not But then you see at the final end of these guidelines that I think this is a paragraph that the whole commission say we do not know it. Because after quantitative risk assessment as a risk-based treatment, decision is uncertain, clinical knowledge, experience and skill, and I think then they want to say medicine is more an art than science. Because in all the other languages, laat de medicine in France, in Dutch is geneeskunst or geneeskunde. So what have the people not read? And this is a kind of the fine print of the whole issue in the guidelines, and it is a little bit of ammunition because AHA and HCC feel very frustrated because if you talk to the physicians, everybody say we like much more the National Lipid Association guidelines. And if the current clinical trial data do not indicate what the targets should be, because nearly nobody ever targeted, it was just the trial with atorvastatin high dose versus low dose, and even the pravastatin versus the, so it was just, they looked what the lowest level would be, and they say, yeah, we need to go below 70. It took about 20 years. Then the magnitude regarding the atherosclerotic risk, I think that needs to be defined. Either you go, for instance, for other tools, calcium score, if you believe it. Carotid IMT is not so good, but that could be a help. Once you have a CAC score and you start statin, you can never use it, or you have already started statin and the patient is hesitating and is in his 30s, 40s, or 50s, and say, I do not want to take it anymore, have a family history, and then you would use the CAC score as a secret weapon. For once you start statin, you will have a regression of the plaque, and then calcification at the final end. And then the whole issue is the lower the LDL or the lowest, the best. Still, this is all debated in maximal statin therapy, and we all know that I would say 50 to 60% can never tolerate maximal statins. So let's go to the National Lipid Association. Perhaps are most of you familiar with these guidelines? There they go back and say, let's stick to the old ATP3, either the LDL goal or the non-HDL goal, and then the low risk. So this is kind of the first part as a warming up. I discussed with Steph and George. Should we say a little bit regarding Ezetimibe? Is it completely out? Because you will see more and more patients who give your nurse a call and say it's not reimbursed anymore, but it will become generic. And the reason why I brought up is it's very rare that the FDA calls all the voting members to get back again to do a vote regarding Ezetimibe, which is now used more than 10, 15 years, which $6 billion have been sold regarding Ezetimibe, and now everybody starts to say, does it work, yes or not? I will not go over the mechanism. When it added to the statin, further reduction 23, 24. If you look to these reviews, I think this is exaggerated. I think if I would have the reviewer, I would have given them a much harder time to write that down. I would say in daily practice it's about between 10 and 15%. So, you know all the design of the improved trial? Does it give any benefit? Here they wanted to look should we go below 70, 65, and they projected that they would come between the 50 and the 60, and of course the safety. You see here the whole nightmare. If you look to the first design slide, when the improved trial was developed, you see here that would be a no-brainer. They expected that the improved trial would be done in about 3-4 years, based on everybody they would enroll. And perhaps people under you remember that the improved trial lead that Wall Street and Washington changed the rules, that now it's obligatory when a company does a clinical trial that for the stockholders of the company, they have to report how the trial is going. Because there was so much pressure, Merck didn't want to talk about the improved trial, despite the enrollment was relatively easy, was fast done, but the problem was, they didn't see too much events, and I think that's not completely true. I think the curves didn't separate too much, and here you have first the results, but I show you this, and you have seen it, a hazard ratio of about 0.936 with a confidence interval, the p-value, and then a very neat number. You can treat 50, and then you will save an event. Do you see how long it lasts? Was more than 7 years. The curves start to separate a little bit after 1 year. So that means if it would be now, if it would be pure anti-inflammatory, you would expect that the that the curve is separating a little bit more. Let's look now, but it's still promising. This was announced as a kind of a blockbuster by the TIMI group. All cause of that didn't change. The CVD didn't change. The coronary heart disease, MI, that was significant reduction. Stroke was just borderline or non-significant. It depends what they wanted to use. Ischemic stroke was significant. The revascularization, and then you see unstable angina not, and then their primary endpoint was significant. So these are the conclusions, but I take you back to the European Society of Cardiology, and I will tell you the little story. The former chief of cardiology of the Erasmus University Hospital, Ceres, the guy who did this interventional study, Martin Siemens succeeded Jos Roeland, and I might say in public, the chief of cardiology got diabetes. But he would announce that even on all the symposia. So that's the reason that I may say it in public, because you will hear the whole story. So they present the improved trial, they discuss it at the European Society, and I think his blood pressure was rising still 250. I've never seen his face so red. And I know him for about 25 years. Because once the conclusion is projected, and I will not show it the previous slide, the chairman said that he does not believe that Ezetimibe is such a wonderful drug. And so the Harvard group start to argue and say, yeah, number needed to treat, and so on is 50. Is that not a good thing? And then they looked already in detail, and he starts to wrestle with him, and he said, it's not so bad than you think, because the reaction was that you want to destroy completely the improved trial. And he said, no, It has some benefits for diabetes, but is that really enough to give it to everybody to lower further the LDL cholesterol, even if you believe in the LDL cholesterol lowering theory? And I do not know if you have seen that table. You saw already this SIP analysis for diabetes, because there were about I think 25%, you will see it on the next slide, diabetes, and so they started to dissect, because a study which lasts 7 years, which gives only a hazard ratio of about 0.94, is very weak, and the probability was, I think, if I remember, 0.016. You expect at least more than 0.01 or 0.001. And you see here, no diabetes and diabetes, no difference in that. Myocardial infarction, what you see here, if you have no diabetes, it doesn't do anything, despite it lowers your cholesterol. If you have diabetes, then 16 significant reduction. Ischemic stroke, if you this in diabetes, it's significant. If you go for the global endpoint, and that I think it was relatively clear. Remember, it was P 0.003. If you look to the non-diabetic patients, there is no significant difference in outcome. So that means that it's mainly the beneficial effect that you see in the whole IMPROVE trial is thanks to the diabetic patients. And so then you saw their strategy. After that whole wrestling of the IMPROVE trial, of course, they wanted to still say it's a great study, it's very beneficial, and they say you have a 24% reduction in myocardial infarction, 39% reduction in ischemic stroke, primary endpoint minus 14%. But this is only in diabetic, and only 27% of the whole patient population was diabetic. So all the others didn't benefit. So the main conclusion is that the IMPROVE IT trial is very, very small, very selective. They are still looking who were these patients who got diabetes, how were they defined, and how was the diabetes under control. Then I see Jeremy Markovich is now back. He was looking to the stock market. I just announced, but you were not arrived. Keep your euros, because the euro went up today to 1.14, and when you were in Rome, it was only 1.08 or 0.7. So you see immediately that the healthcare assurance, but that was from the Europeans, but I think it's the American healthcare assurance have to choose either $14,000 per year for the PCSK9, or first try to add some Zadia and then to go below that 70, and they say $200,000, €2,100 is a little bit too much to save an EPAN. So that was the conclusion. Remember that I told you CVS Pharma defines a medication that they want to have in their pharmacy, that they want to deal with it if it saves a life, which is worth $50,000. That's the reason how the health economics deal with it. And so there's nearly no benefit of adding in non-diabetics, and you see here. There is still another issue, but I didn't want to spend more time, and that is regarding the elderly. There is a small group older than 75, and they benefit also a little bit regarding this. So that is in a nutshell that IMPROVE trial overestimated. Ezetimibe didn't do too much, but I thought it was necessary to highlight, because I do not know if you ever discussed that in so detail or in a more analytical way. because sometimes the editorials will give it different attention. I do not know if you want to take a break or I continue with the PCSK9 now. So let's now start before the PCSK9, and then you see again the second slide, how many people are below 70%. I would say only about 40%. Now they project what you could save if you believe in the LDL theory. If you bring the LDL down from these categories, then you would have a hazard ratio or a risk reduction 44%, 49%, and 56%. So if you look based on that meta-analysis in about 38,000 people, that you say more than 40% of the people do not reach an LDL less than 70. If we would do it, look how much you can save. I think at that time, it's time for a garage sale in a lot of cath labs, because there will be too much to intervene. So who would benefit? Because now you have to look for something new, and who would be your target? Familial hypercholesterolemia, especially the homozygous, because you have to do apheresis. Each apheresis every 2 weeks or every week is about $3,000. No medication. I have no slides. Have people heard about mipomycin? Mipomycin is an injectable and approved orphan drug medication for familial hypercholesterolemia. You inject it, your LDL will go down significantly, but it has a lot of side effects. It can cause liver fibrosis. It will give you fatty diarrhea. So you need to buy Huggies number 6 if you are running around. And also every day you have to take vitamins because it causes the steatorrhea. And so they end up in deficiency A, D, E, K, the liposoluble vitamins. And the longest study which has been done with mipomycin, because with orphan drugs they cannot do outcome studies, is a maximum 24 months. So that's the reason. I think I'm very concerned regarding the fibrosis that they found utilizing MRI. Diabetes, of course, is a target, and you see now the link that healthcare insurance would go for the payment of the PCSK9, but they have ammunition and they say we cannot pay before you would add Zadia. That I expect will be further done. Then the intolerance of statin, I could entertain you for a whole hour. I will not do it. It's very difficult because there are 11 different definitions of statin intolerance. So how will you ever sort that out? Because most people will never develop CK elevation, and some people who have CK elevation, if you want to do lipids, tell the people at least that they do not go to the gym the day before or the morning, because their CK could be borderline elevated. So let us now look to the whole history in the PCSK9 inhibitors. I think it's a very fascinating field, because in 10 years they have achieved so much regarding the development, and it's also kind of the introduction of using antibodies for risk treatment on long term. Antibodies are already used in rheumatology, pulmonary disease, and so on, but it's the first time that it's introduced in, I may not say in cardiology, but in cardiovascular disease prevention. So I do not know if Scott Wright, he showed you the whole machinery regarding the PCSK9. I will be very brief because I thought it would be interesting because one question everybody asks, if you claim regarding familial hypercholesterolemia, you have so much mutation, will it work there? And at this moment, the only familial hypercholesterolemia study which is finished is by Amgen. The others are still going on because you can have certain mutations that it would not work. So here on this slide, you see, and it's a very good recent article review published in the European Heart Journal, and I think you find illustrations everywhere. But the reason why I took that slide is at least you can read it, because most of these cartoons are with so much text and so complicated that so the LDL is put in the circulation, comes back to the liver cell, goes then back to the endosome and the lysosome, and then what you see is the LDL receptor with the LDL is completely, I would say, destroyed or metabolized. But for that whole process, the liver cell synthesizes also PCSK9, and if you want to pronunciate it, I will not do it, but here you see the full terminology. So that means that to lower your cholesterol, not with the statin, because what the statin does is in a very late phase of the whole cholesterol synthesis, it delays, and then your concentration goes down. Here you need to have LDL receptors. The classical physiology is your PCSK9 binds with the LDL receptor, the LDL molecule goes in, but then your LDL receptor is also out. That means at the final end you have much less LDL receptors and you can less take LDL cholesterol. So theoretically, if you would prevent that the PCSK9 would bind at the LDL receptor, the process will still going on, but your LDL receptor will not be destroyed. And you see it here. So you saw first, that is what I explained before, PCSK9 goes to the receptor of the LDL, comes into the hepatocyte, you have the endocytosis, endosome, and then you have the degradation of the whole complex. Now you add human antibody regarding the PCSK9, cannot bind, but still the LDL receptor with the LDL molecule goes in the hepatocyte, goes in the endosome, cytosome, and your number of LDL receptors are still there. So you can take it very easily out, and that is the whole cartoon here. You wonder, how was it discovered? And in fact, in African Americans, not often there are studies done regarding hypercholesterolemia, hyperlipidemia, because African Americans have not so much problems of hypercholesterolemia or familial. But there is a very interesting study, and you see here it's less than 10 years old that whole research started. Everybody is familiar with the ERIC study. It's an epidemiological study. It's like the MESA, the CARDIA, and so on. So what they did was, they take only the African Americans and they look for mutations for the PCSK9. And you have here the frequency of the mutations. because they were surprised why African Americans have lower LDL cholesterol than the Caucasians. And you see here the mutations, PCSK9, the 142, and the others, and then their LDL is lower, specific with these mutations. And then if they look for coronary artery disease, there is a huge difference. So that means they go further into the research and they say, because 88% is very dramatic, and there was no therapeutic interference. So Amgen, which has a huge expertise in antibodies, they say that would be very interesting to develop an antibody subcutaneously to antagonize that PCSK9. And this is kind of Michael Coran, but I thought it was very interesting because psychologically it was a whole debate. It's like a therapy of diabetes where the cardiovascular patients accept subcutaneous injection with antibodies which lowers the LDL cholesterol. And Marianne Berman is my study coordinator who she has more than 30 years experience in all the lipid lowering compounds which have been developed. But she works now 4 to 5 years with PCSK9 inhibitors. We were surprised in the beginning that people, they accepted very well the subcutaneous. You see here the concentration of the antibody regarding the hours. The Alirocumab is the antibody, and then you see that the free PCSK9, of course, if you block it, the concentration are low. You could immediately ask the question, can the PCSK9 concentration learn us something regarding the risk? The answer is no. There are some studies where they have measured concentration PCSK9 as a risk marker. It's still not clear. You will see there is in one small pilot study with Alirocumab in the HIV population in San Francisco, because PCSK9 interacts also with the HIV virus at some white cells. So what they now do is, we all know that HIV patients are on a fast trajectory for cardiovascular disease. Remember that pitavastatin study. So what they do now there, they are using the PCSK9 not only to study the lowering of the LDL, but also to see regarding the CD4 count and so much. And you see here the dramatic change of the LDL cholesterol over time. So no, any other medication never did it. This is after a one single injection. Of course, the first thing that you want to do is it safe? How do we administer it? With side effects? Think again at the brain. And I will discuss with you, I will go relatively fast because the first question is, you have now 3 PCSK9 inhibitors. The Alirocumab, it will be on the market as Praluent. I have only mentioned it on one slide because I do not want to make here any publicity, but if somebody tells you that they are taking or injecting Praluent, that you know that it's Alirocumab. The other is Repata. You see here the results, stable dose of atorvastatin, 10, 20, and 40 milligrams for 6 weeks. And you see the very nice dose response regarding the Praluent 50 every 2 weeks. So it's only a therapy twice a month, the 100 and then the 150. And your LDL goes down with about maximum 72%. So this is huge. The whole question was, can we do it once a month? The answer is yes, but you see a little bit more a yo-yo effect. I think the ideal time is perhaps the injection every 2 weeks. I will come back on that because for the familial hypercholesterolemia, they would go for an injection once a month, but with a higher dosage. The Alirocumab, what you see is that the maximum dose will be 150 milligrams. They will not go to a higher dose. You see here again the Ezetimibe. The change is the same, but look at these results, what you can obtain regarding the lowering. So let's now go on long term. I will show you the side effects too. Perhaps you have seen presenting these studies or you have read it in the New England Journal of Medicine. The Odyssey long term, 52 weeks. You see here the difference regarding the LDL, nearly 62%. If you now project, and I say if you now project the major adverse cardiovascular event, but it's very interesting if you look to the New England Journal of Medicine, if you look to the real figure, these lines are nearly not separate. 0.01, 0.02. That's the reason why I projected that figure to bring you back with your 2 feet on the ground and not to be too euphoric, because you see what publishing can do. If you see that, you think this is a new miracle. Hazard ratio of 0.52. That was the dream of the witch of the previous guy who published the article of the real world. You remember your person decrease, and you think atherosclerosis is over, because who will develop a myocardial infarction, a risk reduction of about 48%. The confidence intervals are very nice. It's not like the damn IMPROVE trial where everything is coming closing to 1. And for such a small group, you have a P0 equals 0.02. That's it. So a little bit another, I will show. And now what are the side effects? The first side effect is nearly no difference. Placebo, 10 that, Alirocumab 8 that, but 0.8. So myalgia. Is a little bit bizarre because the issue was on top of statin, and the placebo group was also on the same dose of statin. So people need to look further in that. You see the neurocognitive the neurocognitive 1.2, 0.5, but it's relatively small, 18 versus 4. In Flemish and Dutch we say where there is smoke, there is fire. I do not know what expression you use, but at least that's the reason that in each study now there's huge sub-studies for neurocognitive function, neurological events, the percentage is the same. So the most frequent, that was the cardiovascular, some allergic reaction. I will comment more on the compound of Pfizer, because the Sanofi and the Amgen are real human antibodies. The Pfizer compound is humanized, because you can have a kind of, at the injection plate, a little bit an allergic reaction like urticaria. If you ask the patient to put some local 1 or 2% hydrocortisone cream, it goes away. But then you see local injection site, 5.9, 4.2. I think sometimes that's hygiene too. If you have a study patient who only takes every 2 weeks a shower when he injects it, but after the injection, you will have some urticaria. Regarding the liver test, I think nearly no problem. So remember, neurocognitive function, neurological events, that will be a hot topic in the future, as well that myalgia is not clarified, then that there is a favor for that. Now you have the other compound, the Evolocumab. So each compound which will be developed will be added on QMAP. So that's most easy to remember. And you see here the difference because there is the race. What will be the best PCSK9 inhibitor? My answer is at this moment, it's again minus, I would say the mean minus 39 to minus 59% on all the different studies. Here, it's already a little bit more realistic. The 1%, but do not forget, now they put a percent here, and the other one was 0.01, 0.02. So I would say they got the trick to do a little bit exaggeration, but in another way. So if you want to publish something, look to the PCSK9 inhibitors. if your numbers are small, how you want to sell a little thing. Minus 53%. I think you see the trend in each PCSK9. I think this cannot be a coincidence anymore. Here the confidence intervals are much a little bit nicer, and the probability too. So in other words, I think it could have a very important potential. Side effects, I think they put more emphasis regarding the pain in the joint, the headache, the reaction regarding the injection. That's always 4 to 5%. In the real human antibodies, if you still worry about the neurocognitive events, it's 27/4. But these neurocognitive events, these tests, so Marianne Berman does it with Kathy Kraft. It takes a long time for the patients, and we have done it by ourselves. You have to be very alert not to make any error, even if you're not taking any PCSK9. So where are we regarding the familial homozygous hypercholesterolemia? This is a study of Castelline, published, I would say, a few months ago. I think now it's completely published, but I made a slide when it was still before print. You see here maximal tolerated statin and other lipid-lowering therapy. It's Alirocumab, 75 and 150 twice a day. A very nice decrease. The whole issue is that a sign that it will work in everybody with familial homozygous? I doubt it. Because here, of course, all these patients are recruited from the Amsterdam area, because the most of the familial homozygous hypercholesterolemia and all these studies are coming the axis Amsterdam, Rotterdam, and Europe, Quebec, Montreal, the French Huguenots, and then in the region of Connecticut, Ohio, because the French Huguenots who got all the familial, they moved from Montreal, Quebec to Connecticut and Ohio. That's the most recruitment. You see here the difference in those, once again, all the same. This is an interesting, so the familial homozygous need to be answered. We have only one compound. The other compound is going on. There is also one in Germany going on where these patients still are allowed to have lipid apheresis. Because here, I think Jeremy, we got a huge discussion with somebody, I think now in the 30s, a young patient, very sad story, familial homozygous, LDL cholesterol about 450, horrible family history, and he was one of these patients who took atorvastatin and other statins who got these mental changes. So when he would take statin, he would be ready for the psychiatrist. Well, unfortunately, he was treated for several years by the psychiatrist. When he went for travel or so on, then he became mellow because he forgot his statin, but nobody was thinking about it. And very sad. And then he and his wife, the two parents at both sides decided it would be better to separate. And then at the final end, the first time I see him is the father-in-law come with him because they were so desperate. And they did not have apheresis, and they came to discuss. And I hear the story, I say that's just a side effect of statin, stay away from it. And in fact, it was a kind of a happy end because his character changed completely. He has now apheresis. He won the PCSK9, but it's very sad, despite he worked for one of the major healthcare assurance, they refuse it, they deny it. I think it's of the base that still they have to pay for the apheresis, and if they pay for the PCSK9, it's another 14,000, but it would be much cheaper because now he has every week apheresis, and that's about 52 multiplied by $3,000 per session. Plus loss of work. You see here in statin intolerance, and then they wanted regarding Ezetimibe as a comparator, and you see in my introduction I say -20, -25%. It's I think -50%. Okay, I will not give you all the numbers. Now I will give you a projection, what you need to look for, because the real implementation is, does PCSK9 inhibitor reduce morbidity and mortality? I do not know if you are aware of the three largest outcome trials. You have the Odyssey outcome, with a compound of Alirocumab. 18,000 people will be enrolled. The criteria for eligibility is 4 to 50 weeks post-acute coronary syndrome. They have to be on statin, following evidence-based medicine. The LDL has still, despite they are on a statin, and of course the preferential dose is the high dose in function of the guidelines, more than 70 or equal, and they inject them twice a month, every 2 weeks, and it's like just a pen. The endpoint you see here, the completion was projected in 2017. I think that will be the case. Better news is for Amgen. The trial's name is the Fourier. They have 27,500 patients enrolled. Here they go not only for post-acute coronary syndrome, but for the compilation myocardial infarction, stroke, or PAD. It's like the Capri trial. They take the 3 major atherosclerotic people, you have to take at least 20 milligram atorvastatin or more, or an equivalent. LDL cholesterol enrollment criteria more than 70, and here you can inject either every 2 weeks or every 4 weeks, and you see here the endpoint. They expected the trial finished February 2018. What you hear in the corridors, the good news is that there would be a possibility that the data of the Fourier study would be presented at AHA this year, in 2016. Because if you see the risk, I think it's they have a higher risk than just a 4 to 52 weeks post ACS, because you start statin ACE inhibitor antiplatelet, while MI, stroke, or PAD, whatever time they develop that disease, their risk is much higher that occurs. They dissect or they separate much broader. Then the buccal, not QMAP anymore, but Zumab. This is a human. This is not a real human antibody, but a humanized. So theoretically, you would expect a little bit more allergic reactions. And I think despite we are completely blinded, I think Marianne Berman agreed that, yeah, we have, I may not say trouble, but we see a little bit more side effects by double-blind placebo. Like, for instance, the other compounds are very well tolerated. I can tell you the statin intolerance. We got several people. LDL is always more than 200. People in their 40s or 50s with the coronary artery disease event. 1 year was double blind, then they go to open label, and it's very, yeah, emotional. You see the first time that they see their LDL cholesterol, like one was a CEO of a company, was never below 200, was 92, 84, and we see a trend over time that it goes like lower. Not too much a rebound effect. The other, what I didn't address today, was Lp(a) as an independent risk factor. We know that niacin reduces Lp(a) with about 25%, but the THRIVE, we will never see the results because Merck will not give any penny to do that analysis. But PCSK9 reduces Lp(a) with about 22 to 35%. So that we are in the process to fight somebody from the state of Wisconsin, huge atherosclerotic disease, where the problem is the Lp(a). LDL is also elevated, but I do not know if we got the approval or not. I think we are still fighting for it. Pfizer, you will see, if it's the first and the last time perhaps that they will show you the slides. They are behind, and they intended to do 2 studies, the SPIRE 1 and the SPIRE 2, where they would include 17,000 and 9,000. They feel the heat in their neck of Sanofi and Amgen, and what they did was they amend the whole study, and they will say we did a study of 28,000, and then perhaps that they will still change the name. So if you see another name thing at SPIRE 1, SPIRE 2, they have to have a high risk of CV events, lipid lowering therapy, and it's very interesting. No company wants pravastatin on board. And we do not know why, and we have asked it, because here we often, when they are intolerant, we give a low dose pravastatin. They do not want to answer it. They say that's the protocol. It's either rosuvastatin, simvastatin, or atorvastatin. No pravastatin is allowed. You see here the LDL, they wanted to separate between the 70 and the 99 and more than 100 every 2 weeks injection, and you see here, and I think that will not be announced till 2018. The FDA approval, now a little bit the practical, the indications. You see here, you have to say that patient is on a maximal diet, that they have a heterozygous familial hypercholesterolemia. In homozygous, they still do not approve it. The Alirocumab is a little bit more easier than the Evolocumab because they have this clinical atherosclerotic disease, additional therapy. With the Evolocumab, they accept the homozygous familial hypercholesterolemia theoretically. You see the approval. July, Sanofi paid about 70 million on the table to have a kind of a faster review. Here you may fill in. How do you call that money to put your stack on the top? That's the reason why there is 1 month difference between the approval, because they sent both dossiers, they sent both data at the same time to the FDA. But the difference in 1 month is Sanofi gave about, I think, $64 million for faster review. The dosing we discussed, 75, 150. They want that you start with 75, but in the patients we now see, they have so much atherosclerosis, we get 150 milligrams. The Evolocumab is 140 or the 420. And for homozygous, they recommend to give it once a month, 420. The syringes, it's like a pen, it's all filled. I didn't put the slide in it. You store it in your refrigerator. And then the question is, when do you check for the first time your LDL? 4 to 8 weeks after initiating of titrating therapy. The most frequent side effect, we discussed already, injection site reaction, but the stuff he knows. It's like if you see them or they call you at the phone, you think they have a cold. And then you know that they will report the side effect of a nasopharyngitis. Because in the beginning when they called, we thought they got a dripping nose or so. They were stuffed at the beginning of sinusitis because nobody knew that it was due to the PCSK9. So that is the issue, I think, here in Minnesota. The healthcare assurance, which is more up to date, is very rare. We got the opportunity to discuss with Medica and United Healthcare. I was very surprised. A whole group, specialty pharmacy, us, and then the representatives of the healthcare assurance. That is what they want. Here that you go through. The whole discussion was they added Ezetimibe. But that was the whole, so I told him the story. But of course, the reaction is we are in the United States. That was in London at ESC. So yeah, we can live with that. And the success rate is about 5%. I think I would like to conclude regarding this that it's a very exciting time. Antibody therapy. You will, if you ask me, is there something coming new? But I think it's ready to be killed. I am surprised. A company in Michigan, Hemcabene is like lipid lowering medication with the same profile of niacin. That company still wants to do a trial, wants still do, but my view is they have to read some articles of the beginning of the 80s. I think they will have never a good outcome. So if there is any question, do not hesitate to ask. Yeah.
were to say free insurance, how much are they? You'll
think $200, it's not so much, it's the whole healthcare insurance pays for it. I think that young, like I say, the government gives the whole clinical trial for other disease, how much they would pay.
But if there was, they had to pay for them.
Yeah, that's the, so the whole, their argument is that all the antibodies which are used in, rheumatology and so on, that the PCSK9 inhibitors are a cheap market. I can tell you, perhaps the nice guidelines in the United Kingdom and Great Britain. Have you heard about nice guidelines? So the British, was in September in Birmingham, and the British made it very simple. They just found a group to write the guidelines. PCSK9 is out in the UK, still the outcome studies are published. And that's it. So, because I asked them, why they were so emotional regarding, I can understand the evidence-based medicine, but then if you talk to them, they were selected by the government because the government wanted that. Because nobody has to deal with it anymore with the National Health Service. These are the nice guidelines to go Lipid. So.
Yeah, on the previous slide you mentioned if statin fails, our elder was considered to be what agent and much the milligrams and for how long I should wait for it there.
That's true. You know, if you want to comment on that, because we do that at least you have in the trial, at least you have to prove that you failed two. You have to fail one in the statin, you have to fail either rosuvastatin or atorvastatin. And the lowest dose. So if you want to prescribe for somebody, go back to the record because we have that's a nightmare for the healthcare insurance. Some, I mean, not call the name of the healthcare insurance, but it's not United, it's not Medicare, but the others, they even want for cholesterol before any lipid lowering therapy was started. If you are 55 and you started to take your first statin in 1989 after the 4F, rapid before was all fit, have not to tell you what for a nightmare that is. I say a lot, some people cannot get it because they do not find their basic cholesterol. But that's the most dirty stuff of the healthcare insurance because they know that too, that most of the people that not find 25 years ago, their cholesterol before any therapy. If you want PCSK9, most of the healthcare insurance have all the information for their billings. We were at a meeting that Optum in Namara, I think 2 or 3 months ago. I was shocked how much they know over each patient who was for a certain time because they found out their data. If you pay $50,000, you can enter the database of United Healthcare, but they call it Optum because perhaps it's a non-profit. They are not usually considered in full-time United Health. They can track medication because it depends what you will do if you will say stop it. But then they check the refill too. They can, because you will prescribe medication for 12 months, they can, some healthcare insurers come back to you and then say 2 or 3 times was not refilled. Because we did it like, for instance, for Crestor or Lipitor, when it was not generic, what you would do is, if the kind makes the size is nearly the same, then 40 milligrams, they will say take a half. So what you then receive sometimes the message that your patient is not compliant with the therapy that you prescribe. If you prescribe 80 milligrams one tablet a day, and you take it out, of course, these patients will not go 12 times to the farm, or if it is 90 days, for 90 tablets of 80 milligrams, they will perhaps instead of 4 times, 3 times, so they will receive a letter and we will receive a copy that they are not compliant.
Both the fellow and him have asked me about control on card 1.
That's my
What exactly we're seeing from heart failure from, and whether that impacts candidacy for a liver transplant.
She did take it. Excuse me, Dr. Duprez. Thank you.
So I should better write it down, the one patch, and show.
Yeah, and I was looking into salt some more. He was seen by Dr. Rabindra in clinic, and they were wondering about his mitral valve. His gradient has been 8 to 10 on echo. They did a right heart cath and measured the gradient, and it was 5. They called it mild hypertension.
So that would be valvular also, but he has no ischemia?
Not that I know of. Yeah, I think his coronaries were okay. His EF is preserved. I presume there's some degree of diastolic dysfunction. I don't know, just from being a cirrhotic patient. I was trying to read about this a little bit. But his, on that same right heart cath where they measure his mitral gradient, he's got normal filling pressures, so it is a little odd. They were also trying to look for constriction and restriction, and didn't seem to have that.
So I will try that, but I think pulse is the most.
Question, Schultz. I can, do you want me to write it down for you? Karen Schultz was the one they were wondering about the etiology of heart failure. Yeah. And then, I don't remember getting it. Another one,
Okay.
But I am going back to the thing.
the phone number is really on your feature.
Maybe when